Welcome to World Parkinson's Program Facebook live session. These sessions are interactive and we like to talk to people about their questions. Sorry for disruption. So any questions you have, please feel free to ask. We will be trying to make it interactive so that all of us can have equal participation. Please forward this link and tell about these sessions to other people so that they can join us. And also, when you are joining us, please let us know where are you joining us from. So thank you for joining us, and we will be taking questions. We have a question. Why do Parkinson's patients get numbness in their feet? So the question is, why do Parkinson's patients get numbness in their feet? The numbness in the feet could be due to many reasons. First of all, a good number of patients do feel numbness, tingling, or other sensory symptoms in their feet. These are mostly involving their toes or feet, and these symptoms could occur or may occur mostly at nighttime or early mornings, but sometimes they could also occur in the daytime as well. There are many different causes of numbness in the general population. The same causes which are responsible in the general population may apply to patients with Parkinson's disease. In addition, there could be certain sorry for interruption. We are having someone calling us on cell phone again and again. So there could be some additional causes in Parkinson's patients. In general population, the numbness and tingling is likely due to sensory nerve involvement. The most common cause of this is nerve damage or neuropathy, or sometimes referred as polyneuropathy. These symptoms are seen mostly in diabetic patients with diabetes mellitus, and in patients who are elderly, these symptoms could occur as well. There are small nerves and large nerves. So small nerves get affected with diabetes and other metabolic diseases very early. Therefore, these symptoms may be indicative of small fiber nerve damage or small fiber neuropathy, and slowly they could progress. So as I mentioned, diabetes is most common cause. Otherwise, due to some unknown causes, these could occur in elderly patients. In other patients, these could be due to vitamin deficiencies, as well as sometime if these patients have back problems and they get these problems of nerve root involvement or nerve pinching, commonly referred as nerve pinching in their back. So this can also cause the numbness in the feet of these patients. So sometimes these could be related to Parkinson's disease. There has been increased reports of having neuropathy in Parkinson's patients. We have another question, so we will come back to the numbness of feet in a while after we take the other question. Someone is joining us and they are saying, how common is sleep apnea in Parkinson's disease? Is CPAP recommended even if vivid dreaming also occurs? Sleep apnea is a sleep-related condition on its own. Patients who either are obese or due to some other reasons, they get apneic spells during sleep. It means that they have difficulty breathing during the sleep, and these patients commonly snore. They are overweight, and these could be due to obstructive reasons, that their air passages are smaller, and therefore they have difficulty breathing, and especially most experts think that during sleep these muscles may be relaxed more, and therefore the obstructive sleep apnea becomes more prominent during sleep in these patients. And there could be some other reasons for sleep apnea when sleep apnea occurs on its own. There have been some reports that sleep apnea could be seen with increased prevalence in Parkinson's disease. However, this is not agreed upon that this is an associated non-motor symptom of Parkinson's disease. Sleep apnea could affect many Parkinson's patients, especially if they are overweight. Those patients who have sleep apnea, they should be independently evaluated by sleep experts. They may need sleep study, overnight polysomnography, and then if they are found any cause which is causing the sleep apnea, should be addressed. Is CPAP recommended even if vivid dreaming also occurs? Vivid dreaming in patients with Parkinson's disease is mostly related to medications. Medications, especially levodopa, is a common cause of vivid dreaming in these patients, so it may not be related to sleep apnea. So if these patients have vivid dreaming, then we may need to modify their medications, or if vivid dreaming becomes a problem, then these strategies may be used. So I'm not sure if CPAP would be helpful just if patients are having vivid dreaming. So these patients who have vivid dreaming or nightmares, they should be assessed independently about the cause of these problems. And another question we have, how to differentiate MSA for PD. So probably they mean to say how to differentiate MSA from PD. MSA is multiple system atrophy. It's a type of atypical Parkinsonism, and many of the symptoms of multiple system atrophy could be very similar to Parkinson's disease, especially in the beginning of the course of multiple system atrophy. So it needs quite a bit of expertise to differentiate multiple system atrophy from Parkinson's disease. Multiple system atrophy patients have certain features which, if assessed very carefully, could lead a neurologist to the direction of multiple system atrophy than idiopathic Parkinson's disease. Patients with multiple system atrophy, they usually have more autonomic features. These patients have more disturbance with bladder, so much before the onset of their symptom. They may start having bladder symptom, urinary bladder symptom, increased frequency of urination, urgency of urination, and leading to difficulty control of bladder. So in patients with idiopathic Parkinson's disease, the urinary bladder related symptoms don't usually come in the beginning of the course of the disease, and after some time, when patients have Parkinson's disease, maybe after several years, then these patients start developing bladder-related symptoms. The bladder-related symptoms in multiple system atrophy would occur in the beginning of the course of the disease, and also in addition to bladder-related symptoms, other autonomic symptoms such as sexual dysfunction. Sexual dysfunction in patients with idiopathic Parkinson's disease would also occur after several years of having idiopathic Parkinson's disease, whereas in patients with multiple system atrophy, if the history is taken carefully, then even before the onset of the symptoms of Parkinsonism, the symptoms of sexual dysfunction, difficulty attaining erection, maintaining and completing the act may be a problem in these patients. Women may also have decreased libido. So this history goes usually before the onset of motor symptoms of Parkinsonism. In addition, patients with multiple system atrophy, they may have dizziness due to drop in blood pressure when they assume an upright position from supine or from sitting position. When they stand up, their blood pressure drops significantly, so these patients feel lightheaded. One way to check is that patients should lie supine. You should check their blood pressure, and when they they stand up, their blood pressure should be checked again. So the classical definition of postural hypotension or postural drop in blood pressure is the drop in blood pressure of 20 degrees in systolic and 10 degrees in diastolic. However, patients may have much more drop than this, or sometimes even a lesser drop, but these patients may feel lightheaded. So postural drop in blood pressure may start at the onset, of course, of Parkinson disease, at the onset of multiple system atrophy, or at the onset of Parkinsonism. Whereas in idiopathic Parkinson disease, the postural drop in blood pressure may start after several years of having idiopathic Parkinson disease. Similarly, bladder dysfunction, as I mentioned, as well as sexual dysfunction may start. In addition to this, these patients may have diarrhea with constipation alternating. In multiple system atrophy patients may have diarrhea, then they may go into constipation, and then bouts of diarrhea. So this alternating diarrhea and constipation picture may lead one towards the diagnosis of multiple system atrophy. In addition, usually patients with multiple system atrophy don't have a tremor. The typical resting tremor, which starts on one side of body, is mostly seen in about is usually seen in about 70% of Parkinson disease patients, and it may start from one limb, especially upper limb. Whereas in patients with multiple system atrophy, usually there is no tremor, or if there is any tremor, that is on holding arms outstretched, or you can see that tremor which is on finger nose testing, especially when approaching the target. Because multiple system atrophy is divided into cerebellar type and the Parkinsonism type. In cerebellar type of multiple system atrophy, you can see that tremor, which is obvious on holding the upper extremities, or doing finger nose finger testing, and when a person tries to approach to the target on finger nose finger testing, they may have a tremor, which is due to cerebellar involvement. In addition, patients with multiple system atrophy, they may have earlier onset of speech involvement. Their speech could be of a scanning variety, like they would scan their sentence. So they would their words would be slightly separated as compared to patients with idiopathic Parkinson disease, who usually don't get problems in the beginning of the multiple system atrophy. There are many other delicate differences. However, there is a significant misdiagnosis of multiple system atrophy into Parkinson disease, since multiple system atrophy is rare as compared to, or is much less frequent as compared to idiopathic Parkinson disease. So patients with multiple system atrophy may be diagnosed as idiopathic Parkinson disease, and it's not uncommon even with patients or even with physicians who specialize in Parkinson disease, that at the early onset of the disease, they may find it difficult to differentiate the two conditions. In addition to this, the symptoms in multiple system atrophy are usually symmetrical. The slowness of movements and the stiffness is found on both sides of body almost equally, whereas in patients with Parkinson disease, you can see that in the beginning of the course of the disease, the symptoms are more prominent on one side of the body as compared to the other side. So the onset of multiple system atrophy is symmetrical. Usually patients have symptoms on both sides of the body as compared to idiopathic Parkinson disease, when the symptoms are usually more on one side of the body. We were speaking about numbness. We were speaking about the numbness of the feet. So numbness of feet, very common in general population, mostly due to diabetes mellitus. In patients with Parkinson disease, if they have diabetes mellitus or other problems, nutritional deficiencies, or other conditions which may affect. Also, sometime due to nerve pinching in the back, the root involvement may cause numbness in the toes of patients. These symptoms are mostly prominent at night time, and if they are more related towards Parkinson disease than when these patients have the wearing off effect of levodopa, then the sensory symptoms may become more prominent in patients with Parkinson disease, whereas if they are occurring due to other reasons other than Parkinson disease, then they may not have any variation with the fluctuation in the with the motor fluctuations or with the on and off phenomena. The numbness in the feet may also be described by some patients who have restless leg syndrome, because they have difficulty describing exactly the symptoms of restless leg syndrome. So sometimes they may use the word numbness or tingling or creeping or pulling sensation. And on the other hand, patients with neuropathy may also use these words to describe their symptoms of neuropathy as the numbness or pulling or tingling feeling, and sometimes due to alcohol use, nutritional deficiencies, or some kind of cancers, especially those cancers which cause protein abnormalities in the blood, may also lead to neuropathies, and sometimes the cancer may be very occult or may be beginning, and patients may develop paraneoplastic neuropathies, which may cause sensory symptoms. So patients with the neuropathies or sensory symptoms of feet may also have pain accompanied with them. So that is one of the reasons that they may have difficulty falling asleep at night time. So they may go to bed and they may not fall asleep till late. So sometimes patients who have numbness in their feet as a manifestation of off periods or as a manifestation of Parkinson disease symptoms. So when the effect of levodopa goes away, then these patients may start feeling numbness, and you can see there could be a pattern of these symptoms towards the end of the dose of levodopa, or you can ask them that just before the next dose of levodopa, their sensory symptoms may become more prominent, and these symptoms may be treated by adjusting the dose of levodopa or adding another medication to levodopa, such as COMT10 inhibitors or monoamine B oxidase inhibitors, or sometimes if you add a low dose of dopamine agonist, if there are no other contraindications, then these patients may have some dopaminergic activity and they may not feel these sensory symptoms before the next dose of levodopa. Sometimes if the numbness is occurring due to restless leg syndrome, so patients may be forced to stretch their legs, or they may be forced to get up and walk around to relieve these symptoms. Sometimes these symptoms may be accompanied by cramping in the legs, especially in polyneuropathy, so that could cause a problem to the patients, and it may cause pain, and sometimes they can see that a muscle goes into a cramp, and it could become very obvious cause of discomfort for these patients. Another question is input on stem cell in patients' testimony, such as in StemGeneX. So the stem cell implantation has been a topic of interest. This has been tried several times. There have been many limitations so far. We don't have a consensus that stem cell is currently a mean of agreed upon treatment for Parkinson disease. There are some countries where these experiments are being done, and some clinics are offering these therapies. However, most experts are not offering patients for this because of a lot of challenges of success. So at this point, in short, in summary, at this point, stem cell therapy is not a agreed upon treatment for Parkinson disease, which is used, which could be used in developed countries. In the countries where the rules and regulations are relaxed, so people are using on their patients. I don't have any experience of seeing such patients from those countries who have undergone the stem cell transplant. However, as I mentioned, most of experts are not going with this treatment at this point. Please join us and ask us questions for sharing knowledge, and please forward our link to other people so that they can join it as well. Also provide us feedback if you find the time for the sessions may be changed, or if we may adjust these sessions to some other time or way to make them more beneficial. We have another question: how does the latest drug approved of sulfonamide add on to old effect of patients that IDCD? Probably this question is about sulfonamide. However, I don't understand this question completely. Sulfonamide is a drug which has been recently approved by FDA. It's a monoamine oxidase B inhibitor, MAOB inhibitor. There are two other MAOB inhibitor. One is salicyline, which is a very traditional medication, has been used in Parkinson disease patients as a monotherapy as well as in conjunction with levodopa. Similarly, another medication which is called rezagiline or Azilect has also been in the market since April 2007 and is used as a monotherapy in mild Parkinson disease patient or early onset with much less deficit, and is also used in patients who are already on levodopa. This is a third medication. This is a monoamine oxidase B inhibitor. I believe the research has been done on about 11,000 patients, and this has been recently approved a few weeks ago by FDA. This is not available in Canada. We have not used it on our patients. Hopefully this would be a very good addition to the already existing drug regimen. We are waiting for the market launch of sulfonamide with interest, and I hope that this would give us another option to add to patients, because when we were using salicyline, some patients were complaining of insomnia. If these patients take salicyline late in the evening, then the patients have difficulty falling asleep sometime, because salicyline goes through an amphetamine-like pathway, and it acts as a stimulant in the body. So when it acts as a stimulant in the body, some patients may feel that they have difficulty falling asleep. Therefore, we advise patients not to take the last dose of salicyline later in the afternoon. So when rezagiline came, this issue was resolved. So rezagiline does not cause any insomnia. Rezagiline is once a day in the morning, and there are two dosage, 0.5 milligram and 1 milligram. So rezagiline is started at 0.5 and increased to 1 milligram and is useful in some patients. So now we have a third drug, sulfonamide. We have released a short statement about sulfonamide on our electronic newsletter of World Parkinson's Program, I think last week. So there was some information in that newsletter about sulfonamide. Hopefully this would be helpful to the patients. Please let us know where are you joining from. This gives us some feedback that people are joining us from different parts of Canada or US or North America or other parts of the world. We would like to adjust the timing of these sessions after seeing where the people are joining us from, because we were doing these sessions on Sunday mornings. I think was 11 a.m. at that time. In West Coast it was like 7 or 8 a.m. so we found it difficult for people to join us. Therefore we have moved the time to 3 p.m. Eastern Standard Time so that people from the West Coast can join us as well. And in Europe they should be evening time, as well as in Indian subcontinent. This may be late evening time or early night time. So we would like your feedback about the time or about any other suggestions how we can make these sessions useful or a day of the week. So please let us know where are you joining from, and talk to your friends, and pass this link of www.pdprogram.org. Go to Facebook and then join us every Saturday at 3 p.m. So we welcome your feedback. These sessions are interactive, and we like to share our experience as a student of Parkinson's disease. I'm also learning every day from my patients or from scientific literature how to manage Parkinson's disease in a better way. So please join us. So we were discussing about the causes of numbness in patients with Parkinson's disease. So then we spoke about some consequences of numbness or sensory symptoms of Parkinson's disease. Sensory symptoms in Parkinson's disease patients. I can't see the question. We have to move it up here. We have another question. What is the treatment for numbness in Parkinson's disease? So with respect to treatment of sensory symptoms of or numbness in Parkinson's disease patients, the treatment depends upon the cause. So the physician or neurologist who treats patients with these symptoms, they have to first try to identify what is causing numbness, whether it is due to polyneuropathies, whether it is related to diabetes mellitus, nutritional deficiencies. So then the cause of sensory symptoms could be treated. Once the cause is treated, the sensory symptoms would improve. If they are due to unknown reasons or idiopathic reasons, especially in elderly, then patients may undergo serological investigations, blood tests, which may help to identify then if we can't find any cause, then symptomatic treatment could be done by certain medications such as gabapentin or pregabalin, and sometime medications such as amitriptyline or nortriptyline can be helpful. If these patients have sensory symptoms due to diabetes mellitus, if these patients have sensory symptoms in the off periods of levodopa, then adjusting the dose of levodopa could be helpful. We have a question. Can you tell us about World Parkinson's Program and how it helps those in need? World Parkinson's Program is a registered charitable organization. It's Canadian-based. It's registered with Canadian authorities, and its mandate is helping patients with Parkinson's disease. There are many other local Parkinson's organizations. They are all doing a great job, and they are all helping patients. Most of the organizations are focused on research. They are trying to find new treatments for Parkinson's disease, and we do need research. They are doing a good job. However, the focus of World Parkinson's Program is entirely different than the other organizations. The other organizations which focus on research, so they are benefiting by bringing out new treatments in future. However, these new treatments take several years. They have to be tested before in animal studies, then human studies, then safety, efficacy. By the time they are launched in the market, it takes several years or decades. So the focus of World Parkinson's Program is to help patients today. Those patients who are living today, they are living in Africa, they are living in Asian countries, or in South America, or in North America, any part of the world, and if they have difficulty assessing the treatment, difficulty accessing the treatment means if they can't afford medications, if they can't if they can't afford walking aids, or if they don't have the educational literature about Parkinson's disease in their languages. So here comes World Parkinson's Program. The World Parkinson's Program tries to provide medications free of charge to those patients who are not able to afford. The requests for medications can be sent through the treating physician, the neurologist, or a treating physician who is treating the Parkinson's disease patients, and they once they find out that patients are not able to afford medication, then they send requests to World Parkinson's Program, and these requests are assessed by a committee, and then based on the need and genuine nature of the request, so World Parkinson's Program try to sponsor the medications for these patients, and these patients could be in any country. The other role of World Parkinson's Program is about the walking aids. They provide walking aids. There are certain walking aids which are needed in patients with Parkinson's disease, such as walkers and quad canes, which can be helpful because Parkinson's patients have trouble with their balance. They fall, they get fractures, and fractures lead to loss of independence and many other complications. Therefore, World Parkinson's Program's focus is to avoid falls in these patients. Therefore, they provide walking aids, and in certain countries the walking aids could be quite expensive, and even in our culture and countries, a good quad cane may cost anywhere about $70 to $80. So in patients who are living in poverty afflicted area, they may not be able to afford these healthcare supplies. So World Parkinson's Program tries to help those patients. They have completed some projects of supplying walking aids in countries such as Kenya, and other service World Parkinson's Program is doing about the educational literature. The World Parkinson's Program has developed educational literature about various aspects of Parkinson's disease. I believe there are about 13 or 14 different educational brochures about various aspects of Parkinson's disease, such as treatment of Parkinson's disease, caregiving, healthcare team, constipation, sleep problems, exercise, falls, driving, drooling, constipation, urinary problems, sexual dysfunction, emotions, hallucinations, emotion hallucination like this. So these topics have been addressed from educational point of view, and these brochures are available now in more than 20 languages. Since Parkinson's disease affects mostly elderly patients and they have difficulty accessing information in other languages, most of the literature available is at this point in English. So therefore, the World Parkinson's Program staff has translated this, or they got this translated, and this literature is available in more than 20 languages, and it's used in more than 50 countries. A lot of Parkinson's clinics are using this literature. This is loaded on the website. About 15 languages are already loaded on the website. There are some which need to be loaded, and they can be downloaded and printed free of charge and given to the patients when doctors are seeing these patients. So that is the role of World Parkinson's Program. In addition, they also provide some other services, which the detail of which can be seen at the website www.pdprogram.org. We have another question. I have rigidity type on right side arm and leg for 3 years. What do you recommend for start of treatment? Rigidity is a very common motor symptom of Parkinson's disease. It also starts on one side of the body where Parkinson's disease starts, or it may be involving one side much more than the other side. So if patients have right-sided onset of Parkinson's disease, they would have rigidity on right side. Most patients are not familiar with the rigidity, and when the physician examines, they find this stiffness or rigidity in their arm or leg. Some rigidity may be found in neck muscles in patients with idiopathic Parkinson's disease. The treatment for rigidity is multimodality. The best treatment is dopaminergic medications. With the start of dopaminergic medications, patients start noticing improvement in the motor symptoms of Parkinson's disease, such as slowness of movements and tremor, and at the same time rigidity improves as well. In addition, I believe exercise would definitely help rigidity, as well as other modalities if patients have difficulty with their wrist, as in the late stages of Parkinson's disease they may get some wrist flexion, finger flexion, they may become stiff and rigid, so these patients may benefit from a treatment of rigidity, not only dopaminergic medications but also splinting and passive exercises. And in some advanced patients who have developed severe rigidity of the arms, they may have some partial benefit from botulinum toxin treatment. So thank you for joining us today, and if you have any question, please feel free to ask. Is there any question on the screen? Thank you. So we have answered several questions today. There is no more question, and it's time to finish. We will see you next Saturday, 3 p.m. That would be April 22nd. April 22nd, Saturday, 3 p.m. Thank you. Please let us know where are you joining from, and please pass this link on to other friends who you know. Thank you. Again, visit the website www.pdprogram.org. Thank you and goodbyes.